Thank you, Dr. Kamath. That was a masterly talk. And before I let others ask any questions, first of all, few rules. Please, anyone want to ask question, please raise their hand so I can go in order. And then we'll start. And before let the audience ask the questions, I want to ask one question, Dr. Kamath. I think the one of the major reasons the patients with cirrhosis have increased mortality, especially patients who are coming to the hospital with cirrhosis, is the SBP, and the delay in the diagnosis of SBP takes a lot of toll because of inherent the problems in regards to diagnosis. Getting a paracentesis in the ED sometimes is difficult, and then you mentioned about the window time of 0 to 3 hours. And longer the delay, more is the problem in this patient. So procalcitonin is a surrogate marker for infection. And I had, many years ago, I published one study, and procalcitonin has a high sensitivity in diagnosing SBP. So if a patient is coming in and a procalcitonin level is high, those are the patients who probably needs a paracentesis urgently. And versus those who have normal, if there is a delay, probably they will have a less chance of finding an SBP diagnosis. Do you have any take on this?
Yeah, so the good question. So the question here is diagnosis of SBP in patients who come to hospital and the role of markers here. Important to remember, about 30 to 40% of patients with SBP will be asymptomatic, so that symptoms cannot guide decisions. Second, procalcitonin seems to be better for de-escalating treatment rather than starting treatment. I think it's critical that we get the right organism, understanding, of course, that culture positivity might only be 50 to 60%. Any patient with ascites who comes to hospital should get a paracentesis. There's always been the fear of paracentesis in patients with ascites. The guidelines quote our paper, our study of about 1,100 paracentesis that we carried out as an outpatient. That was critical, that the guidelines don't specify that. In the outpatient, 1,100 paracentesis carried out. Highest INR was 8, lowest platelet count 19,000. This is the hepatology paper. 0 complications. But I'm not convinced that it's equally safe in the inpatient because infected patients are more prone to bleed. So my recommendation is, rather than the large bore needle that you use for therapeutic paracentesis, so in the hospital you're suspecting infection, use the narrow gauge needle, the one that may be used to get CSF. Use the narrow gauge needle, and that should not be the patient on which the first year resident is learning paracentesis. Someone experienced has to do that. You can do it bedside, do it with a thin needle, minimize the risk of infection. Why is that important? Because we have guidelines for we know the treatment is effective. Your neutrophil count was high in acidic fluid. 48 hours later, it has dropped by 25%. You know you're on effective antibiotics because remember I said only 50 to 60% are going to be culture positive. If you use procalcitonin, you do not know what degree of decrease really correlates with the infection. So my suggestion would be make sure you have your diagnosis, do a careful paracentesis in all these patients.
Thank you so much. May I invite Dr. Dharmesh Kapoor from India? Thank you for joining, Dr. Kapoor.
Thanks, Sanjay. And as always, Professor Kamath's talks very insightful. It just seems like a story, that he's trying to tell. It makes things so simple. The only thing is the guidelines tell us that we should be using the 3rd generation cephalosporins for spontaneous bacterial peritonitis. I think there should be a rider to this statement, and there should only be the community acquired SBPs, which we see very few of nowadays. And this particular concept of CA, HCA, and NA, this has been around for a while. But many of our patients with decompensated cirrhosis, they keep moving back and forth to the hospital. So oftentimes I think whether there is any actual CA that we see, at least in tertiary care centers. So most of the time it's the HCA and the NA you're dealing with. And I think for them, the primary antimicrobial of choice should be different. It should not be a third generation cephalosporin. The other thing that he did not mention was that in the initial thoughts paper from Barcelona, the New England paper on SBP, wherein they have advocated the use of albumin, which was found to be statistically significant only if you had the so-called quote unquote bad SBPs, which was hyponatremia, elevated BUN, and high bilirubin. I think again that's probably something that needs a revision, and probably one would err on the side of using albumin for most situations, especially in patients who are high melders or who keep moving back and forth to the hospital. That apart, this is a huge, huge, huge topic. You could probably have more than a month's talks, for a subject like this. Thank you.
No, I agree, Dharmesh. And so for those in the audience, an experienced clinician speaking. So Dharmesh, I think this is what you say for both is very true. So first, let's talk about the antibiotics. Second, let's talk about the albumin. There are guidelines. My colleague Seth Sweetser, who's one of the smartest fellows I've ever trained, he always says guidelines make below average people average and make above average people stop thinking. So guidelines are guidelines. They're not the final answer. Guidelines from one society, I do not believe should apply to a society in another country because the patterns are completely different. So my thought would be in India, especially because of MDR and XDR, I think there should be guidelines written about for the practicing hepatologist or the practicing gastroenterologist, which antibiotics should be the first choice or not. Cefotaxime would be a good choice in countries where there's low risk of resistance, but where there's high risk, it has to change. And unfortunately, when we talk about XDR, we're talking about meropenem here. It's an extremely expensive drug. And who knows, we have to try and save it for really bad infections, but that's going to be used commonly. And we already know there's carbapenem resistance. So yes, agree, antibiotics, each country should decide, and each institution maybe should decide what is the best based on their culture pattern. The second about the albumin use, the dose was empiric, 1.5 on day 1 and 1 on day 3. So whether single dose, 2 doses, and the actual dose has not been studied. In a post hoc analysis, the post hoc analysis showed that only more severe disease benefited from albumin. Remember, post hoc analysis, the numbers are always too small to make conclusive statements. So post hoc analysis are hypothesis generated, so that the next study should really be, should you use it for all? So that means you exclude patients who are high risk, and only the low risk patients you give albumin and see whether there's any difference. High risk, use albumin versus no albumin and see any difference. I think that is the study which needs to be done. And if I have to do a study, I'll only look at the low risk. In the high risk, I think it's not a huge deal giving them albumin. I won't do a study because I might risk some patients, but in a low risk patient, I think it's worth testing that.
Thank you. May I invite Dr. Prasoon Jalal? Dr. Jalal, please.
I echo Dharmesh's comment. It's not like a story, it's like a poetry. It's always wonderful listening to Dr. Kamath. My question is, in sick patients, in cirrhotic patients, we always suspect a fungal infection, especially if they're in ICU. And the culture is not easy to grow and find. In your institution, when do you put them on antifungal? I mean, when do you suspect, and do you have a protocol at your place? Because we struggle. I have to always constantly remind our ID physicians that, look, this patient's not improving. Think about fungemia.
So the question, it's a good question, Joel. The question is, when do we use antifungal treatment here? Since there is no standard protocol, it's sometimes dependent on who is in the intensive care, who's the hepatology consultant, and who's the ID consultant. That generally goes. But in general, what we agree on is that at some time, when antibiotics are not working, we have to consider fungal infections. The two most common fungal infections are Aspergillus and Candida. These are the two that we have to try and hit. If a patient has sepsis and unexplained neurological problems, unexplained pulmonary infiltrates, the risk of fungal infections increases even before we get the culture. So we have antibiotics on board. We're doing everything possible. 48 hours is when we reassess. If you think that the lung infiltrate is getting worse in 48 hours, confusion is getting a little worse, that's probably fungal infection in these patients. So that's when you put them on antifungal treatment. And then again, the choice would depend on the consultants. We know the older ID consultants are far better at picking up fungal infection than the younger. And that's where it's the art of medicine. You know, there's this sort of gut feeling, yeah, let's do it, let's not do it. I find my most senior colleagues better at this. It's just experience.
Thank you. May I invite Dr. Dhawan, please? Dr. Anil Dhawan.
Oh, sorry, Sanjay. So I'm not going to say Anita, who's my wife, and she's our liver microbiologist or ID, and she may have some ideas on use of biomarkers in fungus, so BDG, etc.
Sorry, I'm just kind of listening, Patrick, in the last minute. Your talk is very always good to hear about the infections and cirrhosis. I'm a liver microbiologist actually, and manage most of the infectious diseases in King's College Hospital liver unit. So we have a very nice protocol which is biomarker based. We do beta D glucan, and so our protocol is quite straightforward. If the beta glucan is positive, we use antifungal on those patients.
Yeah.
And I think the trend is most important. If the trend of beta D glucan is increasing, that means this patient had fungal infection. So I think that's a very simple protocol, and I think we have used for many years and assessed in more than like 1,000 patients, and very helpful to diagnose the basic fungal infection.
Right.
Yeah. Thank you, Arvind. Thank you.
Thank you. I think Dr. Mayank Kabrawala has a question. I can read the question. It is, which antifungal do you select when it is empirical?
So Anita, maybe you can help with that because we select, we are not allowed to select antifungals, that is infectious diseases.
So most of time, I think it's very important to look the epidemiology in your group of patients. So what we have in our epidemiology shows Candida albicans, 40%, and then we are seeing more and more non-Candida albicans as well. So I think at the moment, if we see very high BDG, increasing trend, we use first line as a enidulafungin, which is quite good actually. And we haven't got that much resistance. But if there's like Candida albicans or oral option, you want to use it for longer duration, then we use switch on to fluid control, and it has to be high dose. So we go for like 400 milligram. And usually, if there is high PDG and decreasing trend 2 weeks, and if there is an increasing trend, then definitely there's something else going on. Then you have to always look for the focus. So I think echinocandin are the particularly anidulafungin is the most important. And some of the center, I think they can use micafungin as well. So that's the other option.
No, and I agree. I see more and more prescriptions of anidulafungin in our patients.
Sanjay, can I ask one more question in the same context?
Yes, yes, please.
So, I know as I was listening to the lecture, actually I was finishing one chart, and believe it or not, I have a patient who has got fungal peritonitis, candida growing in the aesthetic fluid. So, because we're having the same theme, so our transplant surgeons are very hesitant once they develop fungal peritonitis. Obviously, fortunately, it's not that common. What's the, everybody has got huge experience here. I mean, do you feel that there is always a risk that they will have some pockets which will never be able to eradicate, and there will be post-transplant, more complications or fungemia in the immunosuppressed patient? So, do you believe that you can ever eradicate fungal peritonitis if it is especially loculated in the peritoneum?
Original question here, was that patient on steroids?
No.
Or no? Was there anything to suggest a primary bowel problem? Because you have to look for where the fungus came from. So
Right.
either the patient had to be, more immunocompromised, or there was something that was done, some catheter or something, especially if it's localized, makes me think that there was some instrumentation there.
Okay. Yeah, patient has alcohol-associated hepatitis, high MELD in the hospital, recurrent hospital admission with SBP. I'm sure patient had multiple paracentesis.
Yeah.
Um,
I'm only speculating, if it's loculated and fungal, I don't know. But Anita, what do you think?
Yes, sorry, I'm just not um, kind of the fungal infection, as you said, peritonitis. We have treated a number of patients in the scenario you are describing. I think again, I think BD is the monitoring process, and there are two things we have to do. First thing is the source control. It's very important. Make sure that there is no bowel perforation or there is no other source. If there is no bowel perforation, fungal peritonitis is a very common thing to happen in patient with decompensated cirrhosis or acute on chronic liver failure scenario. And if there is a bowel perforation, yes, we need to control the source. And these patients may need very long-term antifungals and sometimes even intraperitoneal antifungals we can use. But yes, they are fully treatable, and we have been successful in treating most of these patients nowadays. In the past, when we didn't have the biomarkers, there were no kind of criteria when to stop and when to use antifungals. And once the infection in disseminated stage, it's quite difficult to control.
Thank you.
So you are not okay with them being transplanted?
No, we do transplants.
You do
Once
them.
we treat them, once we fully treat them, and if our biomarker is negative, we don't see persistent source, then yes, we fully treat them.
Yeah, and I remember a patient that's, I think we treated for 6 to 12 months before we okayed for transplants. It's really a long time, right?
Yeah.
Yeah.
One of the issues that we face, when to introduce the antifungal when the patient is not responding on conventional broad spectrum antibiotics like that, and you mentioned 48 hours, but also we also follow biomarkers. One of the issues the biomarker is like in renal failure, many of these patients are acute on chronic liver failure with renal dysfunction. They're falsely elevated, the beta glucans. Any clarification on that? Like what level or cutoff that we can say, okay, convincingly that, okay, this is maybe falsely positive, or any guidance with regards to that?
So in our experience, we didn't get that many false positive. There are one or two conditions when we have seen false positive is when you give immunoglobulin, and or sometimes maybe it's albumin infusion. But if you look at that, when we compare statistically, there's no significance because most of these patients do end up getting albumin. So I think albumin is out. People used to say tazocine is the antibiotic which causes the false positive, but it's not that case at the moment. We use a tazocine for every patient, and we routinely use this biomarker for assessment of fungal infection nowadays. So as you said, for in renal dysfunction also, I don't think there is any false positive. But if it is, what is most important is trend. If your BDG in the patient is increasing or rising significantly, say twofold, threefold dilution, then I think that is the most important marker to the significant marker in the sense that it is signified that there is something going on. And it's quite difficult to, identify the candida where it is, where the infection is going to be. It can be biliary, it can be urinary tract, because there are some of the sites which we can't culture these fungal or candida from these sites.
Thank you so much for that clarification. Now, may I invite Dr. Rishi Samant? Dr. Samant is a transplant hepatologist at Osner Clinic in New England.
So I have a quick question, Dr. Kamath. You told about inpatient paracentesis in sick patient. So a little bit further, like whenever you have a patient who is in the ICU, maybe early septic shock or early DIC, and they are already on broad spectrum antibiotic, you are called after like 48 hours. Is there really a benefit of doing a diagnostic paracentesis, like really a benefit versus risk of having the DIC causing more of coagulopathy and bleed? What's your take on this?
So Rishi, yeah. So the question here is this: a patient is on antibiotics for 48 hours, is in the intensive care unit. What is the role of paracentesis? The question is, at 48 hours, is the patient doing better? If the patient is doing better, then you're probably treating the source of infection well. Then there's less need to find out. But at 48 hours, if they're doing worse, so my basic rule, my fellows know every day, on every patient, I say, are we winning or losing? If you're winning, we continue the same plan. If you're losing, either our diagnosis is wrong or our treatment is wrong. So at 48 hours of antibiotics, if you're losing, I think I would reassess diagnosis or reassess type of treatment. And yes, I would try that. I think it means this is uncontrolled infection despite antibiotics. I think we have to find out why.
And DIC is also like no paracentesis issues with diagnosis in patients or DIC clinically.
No doubt that patients who are inpatients have a higher risk of bleeding with paracentesis than outpatients. Outpatients is extremely safe, paracentesis. No need to check anything. Inpatient, I'm not sure what is the best test to do to decide that. TEG just makes you a little more comfortable doing it, but we don't know what the appropriate number is. If patient's doing well, pre-DIC, yes, I do a paracentesis, but if you say, look, we're already going into multiple organ failure, this patient is going to die, then I don't want to make the situation worse. So that's the judgment of, have they reached the point of no return or not?
Okay. Thanks.
Thank you. I see Dr. Amit Mandot joining today from Mumbai. Dr. Mandot, would you like to
Yeah,
say, please?
yeah. Good evening, Dr. Sanjay, and good evening, Professor Kamath. Always pleasure to listen to him. My question was the approach to an asymptomatic bacteriuria. Many a times we find these patients we send a urine routine culture as a screening septic screen, and the patients come up with a bacteria, though they do not have symptoms of urinary tract infection. So do we treat all of them, or what would be the approach in a decompensated cirrhotic patient who is sick, requiring hospitalization, having asymptomatic bacteriuria?
Thank you, Amit. First of all, good to see you here. So the question here is asymptomatic bacteriuria, decompensated cirrhosis. So we will divide them into two. So female, asymptomatic, no treatment. Male, not that common to get bacteriuria in males. So that typically if you think there's an anatomical problem in these patients. And if they get recurrent urine infections, again, it's an anatomical problem. In these patients, for one thing, I always like to repeat. So one is you have the culture. Look at the urine microscopy here. Culture may be positive because of contaminant, but if they don't have white cells, save antibiotics. I'm trying to prevent antibiotic resistance in these patients and indiscriminate use. I need symptoms. I need little more than just the culture to say that something is happening there. So symptoms and culture, or white cells and culture, I will treat. Asymptomatic, no white cells, culture positive, I watch.
Okay. Thank you. Thank you.
Thank you. Then I will pass it to Dr. Raj Burma. Dr. Burma, please. Would you be a little louder, Dr. Burma? We can't hear you very well.
So thank you so much, Dr. Bhattapati, for giving me the opportunity, and thank you, Dr. Kamath, for the lecture. My question is about how do you approach asymptomatic index case of SBP in an outpatient setting when there has been no change in the MELD and patient is asymptomatic? Do you get them admitted and culture them and start them on third generation cephalosporin, or even though it's an index case, you would just start them on Cipro or Bactrim, or just like Dr. Mandot was asking, because it's asymptomatic, would you not even treat it because the patient is doing completely fine? Again, outpatient, when we ordered a cell count, it's an index case, patient has never had SBP before, and patient is completely asymptomatic. Thank you.
Yeah, thank you, Raj. So the question is asymptomatic. When you're looking at the acidic fluid and you get a neutrophil count, which is high. So this accounts for 4% of all outpatient paracentesis. So that's our paper in hepatology again. There's an editorial on that. So this may be 15 years ago. So outpatients, we would routinely do cell count. Every single paracentesis, we would do a cell count. In these patients who were asymptomatic, this was transient. It went away even without treatment. Okay, so it seems to be a transient seeding of acidic fluid in these patients, but the immune system is good enough to clear that. Because of that, currently, and I believe that's the guideline, currently, we do not do cell counts or cultures in outpatients if it's part of the therapeutic paracentesis. If it's the first time undiagnosed acidic fluid, you don't know what the source is, then yes, you can do the count. But if you know the patient has cirrhosis and is only coming for therapeutic paracentesis, don't do counts. It causes a lot of anxiety unnecessarily. We don't do it anymore because we know it's not a problem.
Thank you so much for that clarification. That was a very important question. I think many times in our center, we started a protocol like how do we follow and track these patients? Like a vast number of patients are getting paracentesis every day, and then there may be one case out of 1,000 that will be positive, and that will be troublesome.
You don't do it. Don't
Yes.
sell it. Don't check the count.
Yes.
We don't.
Yeah. May I invite Dr. Muhammad Al-Feki? Dr. Al-Feki, please. Thank you for joining again. After a while, actually, I'm seeing you. I will wait. If you're not getting the answer, I'll go to Dr. Benedict Maliakel.
Hi, thank you very much. I think Patrick always, his lectures are telling us that we have to do the little things, and the little things are very important. And we think about all kinds of high level stuff, but that is not important when it comes to the patient. If we do the simplest things from first principles, we generally take care of the patient very well. And I think that's always a good thing to remember, when we take care of patients. Second thing is, I think when a patient comes to a tertiary center, with infection, should we do a top-down strategy after cultures, or should we do a bottom-up kind of, strategy? Because to get the right antibiotic, like you said, the most effective antibiotic. So should we start with the highest first and then within 24, 48 hours go down and be more specific and less, uh, broad, and is that going to help in terms of morbidity and mortality? And the second question is, I think this has been done before in other situations, like in pe dialysis, peritoneal dialysis. Is there a role for injecting IVIG into the peritoneum in patients who have either primary or secondary, prophylaxis of SPP?
Thanks, Benedict. So the second question to me is easier. I have no data, so I don't know what to say. First question is very important, top down or bottom up. So again, I like to differentiate the patient who is not that sick and is on the floor. That patient is bottom up. It's the patient in the intensive care unit. So some take a SOFA score of 8 or more is a time we should go top down. So that is meropenem and vancomycin. And then de-escalate after 48 hours, because after 48 hours, you'd have got your cultures back. You know how the patient is doing. You know which antibiotic might be working, and that's when you make the switch. Having said that, again, not all ID physicians are comfortable with this. They want to save those two antibiotics for situations where you really need it, but some will agree with that. Again, it's a discussion. So ICU, I'm much more aggressive with top down. On the floor, bottom up.
Yeah, I think, ID sometimes talks about antibiotic stewardship at that level. And I tell them, is this the time to talk about antibiotic stewardship? Because it makes no sense for that individual patient. We can't go bottom up.
Yeah, and again, I'm only talking about my place. I think once you drive on the highway for a long time, you know when to speed and when not to. You know when they're walking, when somebody's watching or not. Our more senior ID people are more flexible in changing the very strict rules. The younger people, obviously, they've just joined, they're not there for more than 10 years. They like to follow guidelines much more strictly.
Thank you.
Thank you. Dr. Alfaki, please go ahead.
Thank you, Dr. Satapathy, for bringing Dr. Kamath. And it's always a pleasure to hear to his unique presentation. I just want to discuss this new paper that you related to, Dr. Kamath, in the Red Journal about the new study for increased infection for people who get SBP prophylaxis as a secondary prophylaxis. So this was like an observational study, or this was a randomized controlled trial?
Yes, so good question, Mohammed. So the question here is, the paper from the VA that I talked about, which is online, Scott Silvey is the first author, is whether that was observational or randomized. No, it was definitely not a randomized study. So they looked at all the patients who had SPP and fulfilled criteria for SPP prophylaxis. People are given prescriptions and used it. So they can, in the VA system, they can figure out who, filled the prescription. And there were others who were prescribed it and did not take it, or were not prescribed it. So now we have two groups. We've got SPP, we've got two groups, some who took the medicine and some who did not. And the ones who took it had a higher risk. So it's definitely not randomized.
And this was secondary prophylaxis, not primary prophylaxis.
Correct. I think the primary prophylaxis, they already had a paper showing it didn't make a difference. Now, the secondary prophylaxis, so I don't know if you know, there is what's called a cleared study. A cleared study now has about 7,000 people from 6 continents. So all their data are being collected and recommendations are being made. So sorry, that's my puppy going crazy when he speaks.
Thank you so much.
Yeah. So even that study, the cleared study from multinations has shown exactly the same thing. Those on antibiotic prophylaxis did worse.
Thank you.
Thank you. I think Dr. Sara Yusuf has a question. Dr. Sara Yusuf, please go ahead.
Hello, thank you, Dr. Kamath, for a very informative and very concise presentation. I do have a question. I've noticed, to start with, I'm a hepatologist and a transplant hepatologist. I just noticed when dealing with patients with cirrhosis, both inpatients and outpatients, especially with the inpatients, one of the first signs or the first things I notice before they become symptomatic with whatever infection they have is a drop in their platelets and a slight increase in their INR. And I've noticed that especially with my inpatients, because most of the institutions I work with, we do the blood work every day. And when the platelets are trending down and the INR is slowly creeping up, this is when I get really suspicious. And in these patients, I start doing cultures and doing procalcitonin where it is available. And I noticed that most of the time I pick up an infection. So I just want to know your take about this and if you had any similar experience.
Thank you, Sarah. No, I do not have this experience, but this is very interesting. We are looking at trying to find non-culture ways of picking up infection. If you have a large enough number of these patients, my suggestion is you write this up. I think it's an important thing. So you probably have 100 or 200 patients, you got platelets daily, then you see who had infection and who did not. And you can probably come up with a delta, which is the change in platelets or change in count, which is more predictive of infection. I think it's an interesting idea. It should be very simple to do this study, be very simple. So my suggestion would be do it in your institution, and if you see it works, pick up another institution, preferably which is not part of your big institution, because we want an independent validation. There's probably people on this phone call who might be able to help you do that and see how things go. And I think it's a good idea. I don't know about it.
Yeah, and I just want to add one thing. I noticed, like in one institution where the procalcitonin was available, I always noticed that this goes with an increasing trend in the procalcitonin.
Yeah.
And this is sort of help me sort of pick up these things. Yeah, that would be a good idea to get a study done. Thank you very much.
Thank you, Dr. Yusuf. Could you introduce yourself, Dr. Yusuf, from which place you are and which hospital?
Well, I'm originally from Sudan. I had my gastro training in Sudan. I worked in Saudi Arabia. I had my hepatology fellowship from Toronto and advanced hepatology and transplant from Western University in Canada. Currently, I'm in transition, so I'm supposed to start work again in Saudi in a couple of months. So that's my experience so far.
Thank you. Thank you for joining our forum and platform today.
Thank you.
Any
So,
other questions from the audience? Yes, please, Dr. Kamath, please.
So no, I'll just follow up on. So Sarah, I don't know if you saw last week any JAMA paper, which is from Saudi Arabia, where they looked at multiple centers. I think the lead site was Abdulaziz University, and Arabi was the first author. I think he trained in Canada too. So they looked at automated ways of detecting, they sort of computed it to find out whether you've got infection or not, and to see whether that was associated with better outcome. And they found a better outcome. So maybe you can join those people too.
Yeah, I haven't come across this paper, but I would look it up. The first author is Arabi?
It's last week's JAMA.
Okay,
So
thank
just
you.
go online. When I say last week, it may be 2 weeks. It depends. I read it last week, but it's
Okay, thank you very much.
Thank you. Thank you again. Any other questions from the audience at this time? I see a lot of prominent hepatologists from around the world joining today and from India as well, from outside India. And Dr. Chen, who I just want to know if anyone from the China, Singapore, in that region, and if they want to share any experience, anyone who ask any question.
Dr. Sanjay, can I ask one question?
Yes, please.
Dr. Amit Mandotia. Right.
Yes.
So this is one, if we have time, this is one case which we had last week, a situation very common in India. This lady was a decompensated cirrhotic, very frail lady, sarcopenic, with hepatic hydrothorax and requiring repeated taps, counsel for transplant, counsel for tips, like nothing, the relatives were not really willing intervention, major interventions. Now the thing in her is one of the taps showed a protein, the protein was 4 grams and her ADA was normal. The pleural fluid ADA was normal. The counts were 1500 WBCs, which 90% were lymphocytes. So we just got an HRCT also done. The CT chest showed lymph nodes, 1.7 centimeter mediastinal lymph nodes. So the TB culture gene expert was negative. So this was a case wherein a routine pleural tap for hepatic hydrothorax in a sick cirrhotic revealed a high protein predominant lymphocyte count with normal ADA, with lymph which were there with negative gene expert and at 48 hours tuberculosis. So how do we approach this? Any thoughts whether we empirically give anti-tuberculous therapy, considering it's very endemic? The pathologists were not in favor, so were we, but was one thought among team that we should treat it as with empirical safe AKT. So any thoughts, Professor Kamath, on this kind of situation? And this is a real life scenario just last week, 3 days back.
No. And I must have seen it here. So when you have high protein and lymphocytosis, your differential diagnosis is 3 conditions, 3 groups. One is lymphoma, second is tuberculosis, third is fungal infection. And with my recent trips to India, I know histo is a much bigger problem than I thought it was when I was training in India. So to me, it's one of these 3. The problem with treating with antitubercular is you may miss the lymphoma and you're treating wrong if this is histo. So do you have histoserology in this patient?
No, we had not sent it. We had not sent it. So maybe, yeah.
Yeah. So to me, if histo is negative, I'd go for a biopsy. This smells like lymphoma to me.
Okay. So
Because you've got
biopsy,
lymph nodes, right?
we thought, yeah, lymph nodes were there. We thought of a biopsy. The only thing was, again, a sick patient, whether to go for an EBUS. So maybe we'll just reapproach this. Yeah, we'll be seeing this patient in a couple of days' time. So we'll just kind of follow this up. I'll give the update.
Yeah, and so Amit, this is my usual thing. Question, are we winning or losing? So obviously we are losing here. So either our diagnosis is wrong or our treatment is wrong. So we have to reassess that.
Dr. Kamath, thank you so much for that wonderful talk. I think our audience learned a lot from this. This is a very important topic. The infection and cirrhosis, particularly, is such a broad topic, and you went through so lucidly, so comprehensively. I think our audience truly will appreciate all the invaluable insights that you had given today in your lecture. Thank you again from the on behalf of INEDCAST. I would like to truly thank you for coming to our platform and enlightening us on this topic.